have concerns around quality to ensure that people are getting safe care. So those are cross-organisational priorities, but also ASC ones for me. And thanks, Ian. I think I'm handing over now to Ted.
Thank you, Kate, and thank you, Ian. Can I just cover some of the context that Ian was talking about from my perspective as well, because I think it is really very important. These have been exceptionally difficult months for hospitals over the last quarter, and I think I need to start by recognising the enormously important good work that's been going on at the front line in hospitals. One thing that frustrates me, critical care gets lots of attention, and justifiably so. The critical care work has been extraordinary, but there's also a tremendous amount of work going on in medical wards where most COVID patients are being looked after, in emergency departments and in ambulance services, and staff in all these areas are under pressure. And I need to also pay tribute to the leaders of services, because I think to some extent we always focus on the front line, but this has been an enormous leadership challenge at all levels in the service. And I think we have seen a great deal of incredibly positive work going on. And I think that is something we need to keep coming back to all the time. During the pandemic, we have been using a risk-based approach to inspection, which we've described here before, and we've had lots of very positive feedback from providers about the way that our inspection and reporting and other interventions has been supportive in helping them get the support they need or the resources they need to move forward and improve their services. And just as Ian did, I want to pay tribute to staff who've raised concerns with us. One of the few positives coming out of a very difficult time is the fact that staff have shown they're willing to speak up about concerns, and that information is really very important to us. And I think it shows a real positive cultural move within the system, where this is putting safety first, even under these difficult circumstances. As we move forward into past the second wave of the pandemic, into what I hope will be better times going forward, we will be continuing our approach based on risk, focusing on those services where we identify risk in individual services, or those services where we know they are high-risk services. And we've outlined those in the written report. I won't read through them all in detail, but we keep that under constant review, and we are focusing on risk, and we want to be proportionate in this regard, not to add extra burden to services, but to make sure that we are focusing on risk to patients and taking action, often supporting services rather than enforcement action, to help them provide continually safe care. We're also going to be focusing on recovery, and Ian has highlighted how important it is for local recovery plans to take into account the needs of the workforce to recover from what has been a very difficult time for many of them, but also to recover the services for staff who've been left behind. And we want to work with our system partners, but also with individual providers to support them in developing those recovery plans. I don't think a one-size-fits-all top-down recovery plan is the way forward. I'm very keen that there are local tailored recovery plans developed across the country, and I think the focus is towards ICSs and system working. I think is a great move in that direction. One of the things that providers have said to us, and this is both NHS trusts and independent healthcare, is that some of them have ratings which they believe they have now improved on, and they want us to go back and demonstrate improvement on those ratings. So as we go forward, using the flexibility that is coming out of our current consultation on ratings, we want to be able to answer their requests to be able to demonstrate through inspections where ratings and services have improved. And we'll be developing a programme starting in April to do that, but it will have to be proportionate, and we'll be using a risk-based approach as well in that respect to try and make sure that is the proportionate approach. And just to stress, we are not going back to the pre-pandemic model of inspections that we had. We don't intend to do that in the short term, and in truth, we don't intend to do that in the long term, because we have learned from this pandemic in terms of developing our strategy going forward to a much more risk-based model, which is the intention we took going forward. I think just one added point I want to make is that the pandemic is still not yet over. We still live in uncertain times, and I think our inspection approach, our approach to supporting colleagues working in services has to change and adapt depending on the demands going forward, and we're very much alive to that. So while we have plans in place, we will adapt those and to make sure that we take a proportionate response that is as supportive as possible of services that are continuing to be under pressure. That's all I want to say at this point, so I'll hand over to Rosie, I think. Rosie, over to you.
Thank you, Ted. Oh, sorry, there's an echo. It's gone now. So just to start off with, following on what Ted was saying, I just want to pay tribute to people working in primary care at the moment, because I think that they are still under enormous pressure, and we need to recognise the pressure that primary care services are under. And particularly, I think we ought to be congratulating them on the massive achievement of the rollout of the vaccination program, much of which has happened in primary care. And I think that the numbers are staggering, I think, in terms of the vaccines that have been undertaken and the way that that's been done. And I think a huge recognition for people in every sector, but particularly in primary care, who have been involved in that. So thank you. So the report outlines the list of priorities we have in primary medical services, and just to pull out, I won't go through that list in detail, but to pull out 2 or 3 areas. Firstly, in terms of GP services, as I was saying, we recognise they are under huge pressure, but what we've noticed over the last few months in our programme of special measures inspections is that despite those pressures, many of the special measures inspections that we've done have shown improvements in those services. We have now heard from many practices who requires improvement, have a rating of requires improvement, who have said, we would like to be re-inspected. We have made the improvements necessary. Please come back and re-rate us. And so we feel that it's important, firstly, to make sure that those improvements have happened in the practices that requires improvement, but also to recognise the work that the practices have been doing in those practices with an RI rating. So we will be resuming an inspection programme looking at RI practices. We will be continuing to also follow up on any risk and inspecting any practices that we have risk. As with TED, we will be looking at a much more focused inspection response. We are also exploring and continuing to explore how we use technology so that some of the work can be done off-site and that we have the minimal impact that we can on busy services. The second thing just to mention is I'm really pleased that we will be commencing again the SEND inspections. I think many of us have been concerned about what's been happening with children and young people with special educational needs and disabilities over the course of the pandemic, and I'm really pleased that we're working very closely with Ofsted to again progress that programme. And we will be continuing to explore and develop our monitoring approach that we have been using over the last few months with the transitional methodology. And in particular, we've had a great positive response from the dental sector using that monitoring approach. Very positive feedback about the contact with inspectors, the support and the signposting, and we will be continuing to use that across all of the sectors, but particularly in the dental sector, and following up any concerns where there's a risk to safety. So I think that was all I was going to say at the moment, but if I hand over to Kirsty now.
Thanks, Rosie. So just in terms of the work we're doing around registration, we sort of have a two-pronged approach, really. So the first bit is to continue to prioritise our applications that are directly in response to COVID or creating capacity in response to COVID. So we've done quite a lot of work to support some of the step-down facilities and to support opening of new units and things like that, and we will continue to do that. But I'm hoping as hopefully things start to get a bit better, that work will ease down over the coming months. So we will continue to do that to ensure we're able to provide a prompt service. We're also continuing at pace with our transformation and improvement of our registration service, so that people who are using our services get both an efficient and a timely response back to us. And we are continuing to invest quite heavily in that to drive a much more modern transformation of that service as we move forward over the coming months. Thanks. Back to you, Peter.
Great. Thank you all. Could I just say that each of you have rightly said what great work has been going on in all the providers, both people on the front line and leadership. I'd just like to take this opportunity to congratulate our people. We've had tremendous work over the last year, inspectors putting themselves at risk of harm. We've had people working at home in really quite difficult conditions, and we've had some real leadership challenges. So I just think absolutely right to congratulate what our providers are doing, but I think we should congratulate ourselves as well. I think you've all done a fantastic job.
Thank you, Peter.
So where do we go now, Ian?
Moving on to the rest of the report.
Yeah.
Unless anyone has got any particular questions or comments on our areas of priority, I think Kate's covered off IPC and closed cultures in her section, unless she wants to jump in and add anything else. And then I think probably Ted and then Rosie.
Fine, Ted.
Thank you, Peter. I was going to say at this point just what you just said about our own staff, Peter, because I do think it is important. I have to say, certainly staff within my directorate and across the CQC have demonstrated real commitment both to our purpose and values during this very, very difficult year we've been through. And I think we should congratulate them on their dedication to the work. And I think one of the things that perhaps the outside world does not realise, because so much of what we do is behind the scenes, is how much a difference they make to patients and service users on a daily basis. It's not seen, it's not visible, but it is really important. And I think one of the things that really inspires me about staff is their total focus on the safety and well-being of patients and service users. And I think we need to recognise that. And I'm very grateful for their support over what has been a very difficult year for all of us, for the whole country in many ways. In terms of the updates on in the report, can I just highlight that we are continuing in those risk areas such as infection prevention and control. An area where we are going to be focusing going forward is maternity services. That's mentioned in my report. We're getting increasing concern expressed by staff in maternity services, which I see as a very good sign, because I think the culture within maternity services is beginning to change, and I get a real sense it is beginning to change. One of our themes going forward in terms of our strategy is safety through learning, and that is all about driving a really positive safety culture. And I think there's a real opportunity going forward using our regulation, working with partners across the system to drive a really positive safety culture in maternity services, which I think can be transformative for women and children in those services. So I think there's a real positive developing there, but much work to do.
Thanks, Ted. I think we go to you, Rosie, next.
Thank you. And there's three aspects in the report that are outlined. The first is just to ensure the board are aware of some work we're doing with Ofsted, which is looking at how we develop an inspection of secure schools. Secure schools, the first one's due to open in 2022, and we are working collaboratively with Ofsted to look at how we approach these secure schools. The second item is a progress update on provider collaboration reviews. We are now undertaking our fieldwork in cancer and learning disabilities, and we have teams on sites in 8 systems for each of those areas undertaking that work. We will be talking about the urgent emergency care report as a result of the urgent emergency care PCR in the next item, but that is all going very well. And then finally, the DNA CPR report. This, as hopefully the board have seen, was published last week. I think it's a really important report, and it was a huge team effort to be able to to get to that stage. So firstly, a thank you to all the team involved. It was a really great example of how the organisation, different parts of the organisation come together around a very important area to deliver to deliver a great piece of work. And thank you also to Robert for his board support, his non-executive support into the work. I think there's some really important messages in the report and some important learning. We're really looking forward to working with all parties to make sure that those recommendations are progressed and that the improvements that are so desperately needed actually happen. Thank you, Peter.
Thank you, Rosie, and thanks also to you for the work on that report. So it was really good and very timely. So thank you. Kirsty.
Thank you, Peter. So just a quick update from me on our vaccination program, the regulation of that. We are continuing to make really good progress with that regulatory oversight. We have developed a risk-based tool to doing this, our vaccine process, and we have now sought assurance from 43 of the 57 eligible trusts who are providing the mass vaccine sites. So far, we haven't found anything to raise alarm, and which is good. We're also continuing to monitor the work that's being done in the primary medical services through our current risk-based monitoring activity, and again, we've found nothing to raise any concerns about. We're also continuing to work with NHS EI to support the vaccine uptake and are providing any feedback or intelligence that we pick up through our monitoring back into that to ensure that they're well informed of any areas that we find on the ground. So that's all I wanted to say. Thank you, Peter.
Thank you, Kirsty. You want to say anything on the performance report, Kirsty, or?
That's Chris is going to pick that up, so I'm going to pass it over to Chris.
Right.
Thanks.
Thank you.
Just a
Chris.
few highlights to run through. In terms of registration, so as mentioned before, continue to prioritise registration applications to help support the system's response to COVID. In terms of delivery, simple applications are taking on average 20 days to process, with complex applications taking 113 days on average to complete. In terms of our intelligence to regulate registered services, our performance on safeguarding alerts is 97% and concerns 94%, both against a target of 95%. And as previously stated, we're still seeing an increase in whistleblowing inquiries coming into us. So both safeguarding and whistleblowing continue to be a key source of intelligence, with 55% of inspections that are triggered by risk a result of receiving information of concern. In terms of our reach, since April and up until the 9th of March, 6,217 locations have been inspected, and 48% of active locations have had either an inspection, an ESF call or a TMA call. And in terms of equipping our organisation and people, turnover remains stable at just over 7%, sickness tracking well at 3.2%, and on our money, our revenue budget is forecast to be 12.8 million underspent for the year, with a capital budget now forecast to be 1.7 million underspent for the year. That's it.
Thanks, Chris. Mark, I'm hoping that it's another nil report from you on the cybersecurity.
It is absolutely, Peter. Nothing to report this month.
Yeah, and long may that continue. Chris, I doubt it's a nil report from you on parliamentary activity, unfortunately.
Well, some positive conversations happening. We've submitted some written evidence to the Health and Social Care Select Committee on a couple of issues. One connected to the inquiry on children and young people's mental health. The written evidence we've given here outlines our approach to our work and also highlights some of the key messages from our Are We Listening publication. We know that evidence will be taken into account, and we know the evidence will be published shortly. We've also responded to the Joint Committee on Human Rights, who had a question about care home visitation. We wrote to the chair regarding that to indicate our support for and our the guidance around ensuring that there was access for people from their family members, and how we were supporting that through the communication work we're doing with providers, just to confirm that we are both being very clear to providers that they must provide access, and how we are ourselves assuring ourselves of that fact, particularly when people with concerns write to us. And then again, that information will be published in the short period of time. But they were the main two for me, Peter, in terms of parliamentary activity.
Great, thank you, and thanks everybody. There's a huge amount of ground we've just covered quite quickly. Stephen, you wanted to come in.
Yeah, thanks, Peter. I wonder if, still as a relatively new board member, I could just ask Chris particularly about the dashboard. I'm a huge fan of dashboards. I find them really helpful to see at a glance. So, you know, what's going on? How is the organisation actually tracking its key objectives? How does this one actually get evolved and developed and updated? Because some of the greens in it were last calendar year, the reports towards the end. The strategy bit, hopefully quite soon, can be updated to start tracking, well, how does success in delivering the strategy work? Could you just help me understand how does this whole dashboard piece get updated? How often do you sort of revisit? So which are the indicators that really matter to us as an executive that we want to keep on top of and we want to know how it's going?
Sure, yeah. So this dashboard will cover our performance for this financial year. We've got a business plan that sits under this that straddles 3 financial years. And the work we're doing at the minute is just looking at how we evolve this going into the next financial year, acknowledging that a number of things have been completed or live now, but also it's not capturing some of the work that we're now evolving into aligned to our priorities that I talk to and I took, but you'll see it's not actually mentioned in the dashboard. So that is the work we're doing to just take some of the areas out, but also bring in areas that we're not currently tracking in terms of activities. So hopefully you'll see that in the new financial year.
Good, thanks, Chris. Does anybody else want to raise anything on the executive report? Josh, you've covered the ground really well, executive colleagues. Nobody's got any questions, so we'll seize the moment and move on. Chris, do you want to introduce the Insight report?
Yes, so the content for this issue of the Insight report focuses on the challenges in delivering urgent and emergency care that come that stem partly from the conversations we began almost a year ago with a group of clinicians in secondary care around patient first, where we work with them to understand for secondary care what were the things that made good secondary care possible, what are the things that individuals working in secondary care need to focus on. But this report shares a wider series of learning from urgent emergency care does not just happen in hospitals, it happens right the way through the system. And the report shares some overview of the learning which falls into sort of 3 main themes: access and inequality, safety and staff skills, and governance and shared planning. And we wanted to give this report to aid people's thinking around how systems can change in response to COVID to support COVID recovery, and also to give some sense of where we felt there's some really good practice and where we felt there's some really strong concerns. Rosie and Ted, I wonder if you would like to talk through, from your perspective, some of the key findings from your different sectors.
Shall I come in first there, Peter? Is that all right?
Yeah, of course, Ted.
Okay, thanks, Chris, for the introduction. Board members may remember that in the winter before the pandemic, which seems a long time ago now, but we were really concerned about urgent emergency care and its response to what was a very difficult winter. So going into 2020, we convened a group of specialist advisors from emergency departments across the country to ask them how could we prepare better for the winter that's just gone, the winter 2021. Within a couple of months, that was rapidly overtaken by the pandemic. It was very clear to us on that group that the winter 2021 urgent emergency care was going to be under exceptional pressure because of the combination of the long-standing issues with the COVID pandemic on that. And I think the winter we've just come through has been a real demonstration of that, because we've had the second wave during this winter. And so it has been a very difficult winter, as I said earlier on, for lots of services providing urgent emergency care. We've been out inspecting services during that time, proportionately with a very focused risk-based methodology. And we've had some really very supportive feedback from the services we've inspected around how we've actually helped them improve their care. And I think that's really important. And working very closely with frontline clinicians, I think we've developed a very supportive approach to emergency departments going forward. And those services that have used our patient first guidance, which Chris just mentioned, have found it really very helpful in driving improvements in their services. The problems we've found during this winter are outlined in the Insight report, and they're in many ways similar to what we found pre-COVID. So the basic problems haven't changed. There have been some changes because, of course, the acuity of patients with COVID has gone up. The numbers actually attending A&Es in many cases are down, but the acuity has gone up. And there's been real problems in cohorting COVID and non-COVID patients to try and maintain good levels of infection prevention and control. So in some senses, the queues that we were worried about in hospitals, the corridor queues of patients waiting for emergency care in hospitals, have transferred this last winter out into ambulance waits. And the ambulance waits have been a real concern during this winter, and then the length and number of ambulance waits has been one of the big drivers behind our inspection approaches going forward. The solutions for this lie in the patient first document as a start, and I think that's still something we can build on. They lie within the emergency departments themselves to some extent. They lie also within the hospitals and how well the hospital supports the emergency department, but they also lie in the wider system. And I think one of the things that is really important is that we're presenting this together with the provider collaboration review, which is about how the system collaborates. And I think working together and what we've learned from our inspections of emergency departments with the provider collaboration review, we need to think forward about how we're going to approach urgent emergency care going forward and what the system can do differently. So I'll hand over to Rosie at this point to talk about the provider collaboration review, which I think is a very important part of this picture.
Thank you, Ted. In the provider collaboration review, this is our second provider collaboration review report. And I think one thing I'd like to say is that we continue to work on the methodology, and we continue to learn every time we do a set of these provider collaboration reviews about how we really understand what's going on in a local system, and how we really kind of get understand the really good examples, but also understand the areas that need improvement. We have been looking at four key areas when we've been looking at local systems. One is around looking at making sure people are seen in the right place at the right time by the right person. The second area is about shared planning and system-wide governance and leadership across the system. The third area is around ensuring safety of staff and making sure that those health and care skills across the providers are looked at a system level. And the fourth area is around the impact of digital solutions and technologies on providers and services. We have already shared some examples of some really tangible things that we think can help systems, and those examples there's a link to those in the report. And I think I would ask systems to be really thinking about how they can learn from these examples and how they can learn from the areas that we've looked at in advance of any future spikes in demand that inevitably will come as we go through the year. But just to identify the kind of main challenges that we've seen, firstly is such a reliance on relationships, and we would encourage systems to really look at their relationships within their systems and invest in those relationships. They are so important, and we hear time and time again about how those relationships are so important to meet the needs of the local populations. Secondly is about information sharing. It is something we've raised on several occasions before, but that importance of being able to share information, it came up in the DNA CPR work we've also done, which is very much linked to this, but people being able to understand information in a real-time way and accelerate that work is really important. The third area is around staffing around the system. When we're looking at staffing across the system, we need to look at it at a system level. There's no no point in pinching kind of different members of the staff to work in one service if it's going to leave another service short. We need to be understanding what that looks like right across all of the system, and to be able to enable those system-wide plans for staffing. The other thing just to mention about staffing is that we've seen some brilliant examples of where actually people have had innovations in this area. For example, dental nurses, particularly in the first lockdown, who weren't working, who then went to support the local A&E with their dental problems, for example, and numerous examples where actually there's been some really great innovation around that. Inequality is a key factor that we've been looking at through our PCRs, and we found variation in terms of how much people have been understanding their population needs and how much they've been putting services in place. And I think that's something we would encourage people to do: really understand your population needs and look at strategies to address inequalities. And finally, we've seen some really good examples of where places have used technology in a different way to be able to enable good care. And I think we need to make sure that technology is used in a safe way, in an appropriate way, and that makes sure that no one is disadvantaged from technology. But there has been absolutely no doubt that there's been some huge positive transformations with the use of technology across the system, and we've discussed that in more detail in the report. Thank you, Peter.
Thank you, Rosie. Ted, I understand why or how it is that we've ended up with a lot of patients being held in ambulances, in some cases for many hours. I mean, I obviously understand how that's come about, but equally, it's a really bad place for both for patients to be held, but also really bad for the population elsewhere who might be waiting for an ambulance urgently and can't get it. And I just wonder whether there's some work that we could prompt, not do, but prompt for trusts and ambulance services over the summer to think of how they might avoid this in the future. It really is bad, isn't it? What's happened?
I think it has been a real concern this winter, and as I say, to some extent because of the infection prevention and control concerns within the hospital, patients were kept outside until there was physical space for them in the appropriate cohorted area, and that meant they were looked after in ambulances. And there are different approaches to this. Sometimes in some trusts we found they were looked after in ambulances by the ambulance staff and the trust essentially took no responsibility for them. In others, the trust went out there and provided support in the ambulances. It's unsatisfactory in many ways, but what we're looking for are trusts that actually address the issue in front of them and the mitigation, the risks for individual patients on that basis. I mean, clearly, if a patient is held in an ambulance, it is not good for the patient, but it is not good for the ambulance service and the person who's waiting for that ambulance out in the community. And ambulance services have been under tremendous pressure during this pandemic for this very reason. And I said earlier on that to some extent we need to recognise that they are part of the system that has been under tremendous pressure. I think going forward we need to build a system with sufficient capacity and resilience that can cope with these surges in demand. And that means there must be some of the flexibility we've seen during the COVID pandemic to create new clinical spaces to reflect the surges in demand. We need to build that into our daily work to deal with surges in activity. And I think that the NHS and providers have demonstrated they can show that flexibility where necessary. And I think we need to build that in so that when there is a surge in demand at the front door of a hospital, the default position isn't to leave patients in ambulances, but to create that clinical space, staffed safely, so that patients can be looked after in a safer space. I think it is a big challenge there. I mean, we mustn't underestimate the formidable challenges that the services have faced this winter, but I think we can learn from it. And as I said earlier on, I think a lot of what we saw in this winter, while it was different because of COVID, did reflect the problems we'd seen in previous winters. And so there's a long-term issue there we need to talk about the resilience and flexibility of emergency services dealing with surges in demand.
Thanks, Ted. Yeah, I'm not unsympathetic to the issues people have faced. I just think it's a problem that we need to try and see addressed. Other questions or comments from colleagues? Stephen.
Thanks, Peter. Really interesting report. Thank you very much indeed. The particular bit that caught my eye was page 47 in the set that I'm looking at. We saw little evidence of widespread shared strategies at whole system level. Systems didn't always feel it was their remit to plan for system-wide staffing. And it got me kind of thinking, well, in what ways do these group of people and providers think of themselves as a system at all? Is there a sort of underlying problem that there is no shared understanding of what the system is? There's a group of people and a group of providers sort of working together more or less effectively, but is there that sort of secure understanding of system and its role and purpose?
So Rosie, do you want to go first and then Chris?
Yes, thank you, Stephen. And I think the first answer to that is there's huge variation across the country. We see some really mature systems who fully understand the importance of working together, the providers working together. We see really system-wide strategies around people management and really impressive work that's happening where people are working together. And the other thing that I think we see that's impressive is where you can see that thread right from the leadership of the integrated care system and the communication right the way down to people working on the front line, and everyone understands what's going on across the system and what the challenges are and how they play a part in that. I think at the other end of the spectrum, we do systems where actually those relationships haven't developed, and people working on the front line don't understand what's happening at the ICS level. People don't really see haven't really looked at how providers work together, and I think that is something that we want to look at, how we develop our methodologies and our work in this area. And it's certainly pertinent to the work we've discussed around the white paper, because I think I think we're moving into a space, especially with all the challenges the health and care system face, that actually it's imperative providers work together. It's imperative that systems work together against these challenges. Otherwise, patient care is going to suffer as a result. The only final thing I'd mention is that actually I think how you define a system is a really interesting question. And one of the things that we've heard through our provider collaboration reviews is some parts of the system aren't necessarily very integrated. So, for example, the dental sector doesn't necessarily, although is an integral part of the body, not particularly integrated into the wider conversations, despite the fact that often people with dental problems can end up in A&E or in general practice or other parts of the system if they're not managed properly. So, there is a lot that we need to nudge and encourage from our end in the system-wide work, but I think there's an awful lot of really good work as well that we can learn from.
Chris, do you want to add to that?
Just to quickly say that the point's well made, Stephen. I think some of the work that we need to do nationally to support this is how we develop the right measures of what we ask organisations to do. When we did the work on the system reviews almost 3 years ago now, there were 3 things that are really important: having a common vision for what you're trying to achieve, being able to move the money to deliver that vision, and having some measures of success to determine that had been done. But it starts from a premise that you have a common vision, and often common visions depend on what organisations are asked to do. So Rosie's absolutely right. The ability for us to bring the vision of ICSs and the vision of social care close together so that they act as a unifying force for what then providers do in a local area is I think critical. Just as an anecdote to that, if you look at all the NHS organisations that have improved their A&E performance, moved from inadequate to good, all of them have done that not by just managing flow within their organisation or doing the things that are in patient first, but a lot of things around patient first are about their engagement with wider organisations, good conversations with primary care, good conversations with adult social care. So we know it's critical. It's how we, as national partners, try to provide that common unifying framework that allows good conversations to happen locally between leaders so that they can help each other deliver a common vision, move the money, and have the right purpose that they can then share with their teams.
We talk of systems as if it's a single homogeneous system, but I mean, certainly in my experience, and Ted and Rosie, you're more experienced than I am, you can find places where you've got really joined up pathways in some areas, and other pathways where the system really doesn't recognise any other part of the pathway. So it's quite complex, isn't it? Ted.
Yeah, I think your question, Stephen, is really important. System working and that common vision of systems is really important. But again, what you're saying, Peter, I think we have to understand systems are not closely defined entities. I mean, the ambulance trusts cover vast areas, and they're parts of many urgent and emergency care systems. And we need the systems to be dynamic enough to be able to cope with different boundaries and systems working together. And one area, just as you were talking about there, that we haven't mentioned yet, which is a very important part of the system, is of course mental health services. And I think during the pandemic, one of the things that we've heard repeatedly from emergency departments is that they've seen an increased number of people with acute mental health problems in hospital, and they coming into the emergency department, and they have increasingly found it difficult to find placements for those individuals moving forward. So it's a large, complex web that is the system, and working together has to be really thoughtful leadership, bringing all elements of the system together to make sure it's focused on the needs of patients.
Peter, I wonder if I might just come back in with a follow-up then. So is there then a developmental piece that needs to be done, and do we feel that the white paper is giving us the right framework for pursuing that developmental piece? Because fine, your system may vary from place to place, and we need to be flexible, but if there isn't some common understanding of what a system is, and therefore what good performance of that system is, it's always going to be harder for the CQC to do our core role of inspecting against a shared understanding of what good performance is. So I'm just sort of interested in whether you're seeing, particularly in the framing of the white paper, the space for that type of developmental piece around what Chris described as a sort of shared vision about what a good system is.
Rosie,
so can I come in there? So I think that there are lots of pieces of work. I think there is a huge development piece around this, and I think there are a lot of pieces of work already in train, both within the CQC but with broader organisations. For example, the National Quality Board are refreshing the shared view of quality, which I think is a really important piece for system-wide working going forward. There's work around metrics for systems going on with multiple parts of the different bodies that work across systems. And I think internally at the CQC, I think that we've got a lot of learning already. We've got the learning from the local system reviews. The provider collaboration reviews have been a good way of looking at actually how do we really understand population groups, how do we look at pathways of care, and we're continuing to develop those approaches. I think over the coming few months, we need to then build on those, the learning that we've had from those approaches, to think about how does that then put us in the best position possible with the white paper proposals.
But I think, sorry, Ted, go on.
I was just going to say, if I may, and I think the ICS is actually a really great foundation for this, and I think that's why we support it. What's really important is that each ICS needs to have the autonomy to build the services around the needs of the population it serves, and not have a single model from the centre. And I think if we can make sure that the assurance and governance systems of ICS give them that autonomy, so they can really pull together to build services around their populations, I think that would be a major step forward.
Agreed. Ian.
Thanks, Peter. I think to answer, to have another go at Stephen's question, I think it's a really important question around how do you define what a system is in a particular geography. And I think the fact that the Secretary of State has been quite public about wanting to see ratings in a particular system, I think by definition that forces a debate that says what is a system, how do you define it for the purposes of rating. So I know people have got different views on whether or not rating in in a place is a good idea or not. But I do think that it's going to force an important conversation that's going to wash through some of these questions, because I think my sense at the moment is the white paper on its own doesn't define a system, but the questions that it asks will need to define a system in the coming few months.
Thank you, Ian. Thanks, Stephen. Anybody else want to come in on the report? Mark Chambers.
A quick question, if I could, on the inequalities section, and you'd highlighted the variation in focus and action, but the report also highlights to be quite surprising variation in the data, that underlying data that's available to have that focus and to have that action. Do you want to comment a bit on that, Rosie?
Yeah, certainly. I think that as well, there is quite a lot of variation in the data that's available, and actually even within our own data that we have at the CQC, to be able to look at some of the inequalities. And I know that that's affected the work that's happening with registration and our regulatory platform work. I think we've seen some really examples. So I think primary care networks give us a real opportunity to look at health inequalities and to really look at how they work within their local communities, with all aspects of that local community, including district councils, faith groups, voluntary sector organisations. There are huge opportunities, and the best examples we've seen are where those different groups have come together to look at really understanding the data about their local population needs and being able to plan their services around that. Some of that data, as you say, is not there, and I think that's something we need to understand. And certainly, I think it was highlighted with our recent work around DNA CPR. If you looked at the system oversight and assurance of DNA CPR decisions, which again is very much a system issue, we found that often the data wasn't available if you looked at, for example, the number of people with learning disabilities with the DNA CPR. And I think we need to make sure that we are encouraging systems to look at really understanding what data they need to be able to address these inequalities, to understand them and address them fully.
Thanks, Rosie. Sally.
Yes, thanks, Peter. I wanted to commend the team for the report, first of all. I think this is the next one in a whole series of insight reports that we've had, and they always generate an immense amount of conversation, and I think touch on the really important points that come out of them. So well done to the team. My question was a bit more about wider definition of the system and how we involve adult social care, because I think in all the years I've worked in health, we've talked a lot about ambulance handovers to trusts, and that's still quite an important point, but it's one we've been tackling for a long time. The reality is that most of the issues within systems are about the crossover between health and social care, particularly for older people who don't have a very clearly defined pathway, but might touch lots of points and move from one back in the pathway, forward again, back again. And I was conscious that Kate hadn't commented, so I just wondered if she'd got anything to say about this particular report and the interaction with adult social care. Thanks.
I'm pretty confident, Sally, Kate will have something to say.
Thank you, Sally, but also some of my colleagues have made the point. So I think we need to look at everything through what matters to people, and we know that people's outcomes are so significantly impacted by getting access to the right care at the right time in the right place with the right correctly skilled staff, but also how joined up care is. So it's absolutely essential that people experience joined up care. And as colleagues have said, our system reviews 3 years ago absolutely put the blueprint about what good system working looks like. You know, Chris described a joint vision, pooled budgets, etc. And in our strategy, you know, up front and centre of our strategy is our ambition to regulate through the eyes of people with lived experience. So we are absolutely interested in someone with comorbidities, how health and social care comes together to ensure they get the right support. And that's why it's absolutely critical when we think about integrated care systems that they're not narrow, that they're much broader than health, that they do include social care. They do have, workforce plans that encapsulate the totality of the workforce, including, volunteers, the much broader sector. So I'm really keen for integrated care systems to really deliver what matters to people. They need to be much broader than health. They need to have the right leaders around the table that are people with lived experience, families, social care providers, voluntary sector as well. So much broader. But thanks, Sally.
Great. Thank you, Kate. Thank you, everybody. Board, we're asked to formally agree that the report should be published at the end of the meeting. I'm quite sure we all agree that, don't we? Excellent. So that takes us on to welcoming Henrietta Hughes. Henrietta, really, really nice to see you. You're going to present the National Guardian annual report. So shall I just hand over to you, please?
Well, thank you so much, Chair. And I wanted to start off by just reflecting on yesterday's National Day of Remembrance and thanking everyone who's been involved in the pandemic, all of those who've been working so hard to keep people safe, and particularly thinking about Freedom to Speak Up Guardians who've been supporting their colleagues and ensuring that they've got safe channels to speak up. As you said, our annual report was laid before Parliament last week, and I just wanted to just think of some highlights in that and then obviously have time for questions and answers. So the national network of Freedom to Speak Up Guardians is continuing to grow, and there's now over 600 guardians in more than 400 organisations across England, and that includes all the trusts and foundation trusts, but also a large number of primary care organisations, independent sector providers, hospices, and many of the national bodies, including the Care Quality Commission. And Guardians have been listening and continue to listen to their colleagues and handled over 16,000 cases in the last financial year. And that included a range of cases related to patient safety, around 25%, or 23% it was, and 36% of cases had an element of bullying and harassment. During the first wave of the pandemic, we were hearing that people were speaking up about lots of different subjects, new subjects, including the availability of PPE, fit testing, risk assessments, and we asked Freedom to Speak Up Guardians about their experience. And initially, we heard that people were speaking up to Guardians around these matters as well. And I was very grateful to the chief inspectors with whom I wrote out to all the chief executives across the system. And following on from that, we saw an increase in the percentage of Guardians who felt that workers in their organisation were being encouraged to speak up. We've continued to look at other types of quantitative data, including the Freedom to Speak Up Index, drawn from a subset of questions from the NHS staff survey. And we've seen a year-on-year increase in this. And this is whether workers feel knowledgeable, supported and encouraged to raise concerns, and whether they feel they've been treated fairly if involved in an error, incident or near miss. We've seen once again that organisations rated highly by the CQC tend to have more positive Freedom to Speak Up index scores, and also their guardians tend to have more positive perceptions about the speaking up cultures within them. We've got a new question that's come into this year's annual staff survey, which didn't make it into our annual report, but I think it's worth noting. This is a question which is applicable in all types of organisations, and it's I feel safe to speak up about anything in my organisation. This is the first time this question has been included, and nearly 66.6%, 66.5% of people who answered that question agreed or strongly agreed. Now, there's obviously a long way to go with this, but I see this as a foundation from which we can build. And certainly it would be useful to be able to share that question with non-health providers as well, who've often asked about what questions they can use. We've continued to do case reviews, and we are developing a new case review process so that we can hear from a wider range of workers. And all of the information that we gather from the Speaking Up data and the index and the new question are part of model hospitals, so that with the recommendations that we make and the information that's presented, organisations can learn from each other's successes. And we continue to work in partnership with organisations, including the Care Quality Commission, where we've been providing training to CQC inspectors in the Hospitals Directorate and updated the guidance for inspectors as well. We have worked with Health Education England to launch a package of training. This includes Speak Up training for all workers, Listen Up training for all managers, and we're developing follow-up training, which is for senior leaders, so that they know about how to foster an environment where people feel safe to speak up. And looking to the future, we're going to be looking in more detail at detriment and thinking about what people are fearful about when they speak up and ways that we can help to mitigate and manage that. But we're also developing new online training for Freedom to Speak Up guardians, and we'll continue to work in partnership with many organisations across the system with the aim of making speaking up business as usual.
Fantastic. Good. Sir Robert.
For those who are new to the board, they may not know that I am your representative on Henrietta's formidably called Accountability and Liaison Board, which in fact consists of two people, one representing CQC and one NHS England. But I'm happy to tell you that a light style of governance is really all that Henrietta requires. The progress that has been made by the National Guardian and her team over the last 6 years has been quite formidable, from a standing start where, frankly, there was huge scepticism in the NHS about the value of a system like this. And I think one of the reflections I would have is that what Henrietta and her team have been able to accomplish shows the value of not putting something into law, of allowing something which is a new concept, to develop so that it can be accepted, designed into the system, obviously meeting problems and then addressing them. And I think that it is a testimony to the achievement that it's not only within the NHS and our field, as it were, that this concept is being taken up, but Henrietta runs something called a pan-sector network, which gathers together on a regular basis people from entirely disparate industries, the oil industry, aviation, even banking, dare I say it, sport, various other places, all of whom are keen to share ways of dealing with these intractable cultural issues around encouraging staff to speak up. I'd just like to, obviously Henrietta would agree, I think the work is not yet complete by a long chalk, and there are, I'm afraid, dark corners of the system where guardians, people who speak up, are still treated in a way which is probably unacceptable. And if I can end with a question for Henrietta, just a bold one at her, which is that obviously the primary concern is to allow people to speak up and to ensure they don't suffer a detriment. But I wonder whether you have any comment on what happens after something has gone wrong. Often, and for instance, an alleged whistleblower complains to an employment tribunal, and the matter is then defended to the nth degree, unhappily, not infrequently now, ending up with a judgment against the trust. And I wonder whether you feel sufficient is done to learn the lessons from the ill-advised defence. I'm not saying all cases should not be defended, but the ill-advised defence of some cases involving some whistleblowers.
Well, thank you very much. And I think you're right to say that nobody's got this 100% right. And the more that we can learn from the global network that we have now in our pan-sector network, the more that we can share that learning into the health system for the benefit of everyone. I mean, my take on this is that leadership is absolutely fundamental to fostering the right culture in the first place, and also to be able to respond with curiosity rather than defensiveness when people raise matters. And unfortunately, there does still appear to be a level of defensiveness, which is really unfortunate when there's so much information and evidence around the value that organisations and leaders can get from the gift that is the information that their workforce bring. And I think that there's something about how this forms part of internal governance in organisations, but every single aspect of leadership, whether that's to do with the selection of leaders, the competency framework for leaders, the annual appraisal, the leadership development courses, and also how this fits within regulation as well, so that organisations who are able to cope with this level of challenge come to us and say, how can we do better? Whereas the ones who seem to be struggling more don't have the headspace to be able to make those improvements. And I would really welcome a bigger conversation around how this fits into leadership, how we can support leaders to be effective, and how this can be recognised and rewarded when people are getting it right, as much as there can be ways of challenging and intervening when things aren't going well.
Great, great answer. Thank you. Mark Chambers, you wanted to come in.
Thank you. Well, you know, the work that the Guardians do is fantastic, and I would fully endorse Robert's observation about this. The value of this is not as a compliance exercise. If you make this a discussion at a leadership level about how you meet a regulatory requirement, it's the wrong answer. The value of the cultural value of having a strong speak up culture is a better organization, a stronger organization, because it's one where senior leadership can work out what's going on and get an early warning about things going wrong, and can take early and effective action. I just wanted to comment on a few external things that worry me in terms of coming, their confluence in our space. We've seen some scary surveys in other sectors that have told us that there's been a really sharp increase in retaliation rates against people who have spoken up, and that's enormously worrying, because fear and futility are still the two biggest barriers to people speaking up. People feeling that they won't be listened to and nothing will be done, but also feeling that it will be damaging to their careers if they do speak up. So we're seeing in other sectors a big increase in that, and of course in the sectors that we regulate, we see people under immense pressure. Levels of pressure that are almost unrecognizable, and as we've discussed, are almost unmanageable. And constant pressure leads to constant pressure to compromise standards. I think the third thing that worries me is that we're looking over a system where microcultures are very prevalent, and microcultures are particularly difficult if you're trying to drive consistent cultural standards. So, Henrietta, I'm pleased to see that you're adding new measures to track this. So things, measures that are already in your report about from surveys, and measures that are in your that are in there about the proportion of your reports that are anonymous. You want to get to a point where people feel free to raise their concerns on a named basis. But what are you seeing in terms of those pressures on retaliation?
Well, thank you so much. The first thing I would say is we're always curious about what it is that's causing someone to be anonymous. And when it comes to freedom to speak up guardians, this is not the only speak up channel. Clearly, the most likely thing is that someone will talk to their line manager if they want to raise something. But this freedom to speak up creates an additional confidential channel. And what we found is that in the last financial year, it was around 13% of people raised concerns anonymously to freedom to speak up guardians. And looking at that in comparison with other equivalent sort of channels, the work through the NAVEX global system, the research by Kyle Welch showed that 28% of those reports were anonymous. And that's more of a sort of electronic system rather than a human being. But also, we recently heard from Speak Up Direct, which is the whistleblowing helpline, that 86% of their calls were anonymous and people were withholding their phone number. So I think it's really interesting to say, why is it that so many more people are content to share their details with a freedom to speak up guardian than in other equivalent speaking up systems? And I think that it really shows that guardians are a trusted route. And one of the things which I think is really important about that is that we encourage guardians to seek feedback on their own performance so that they can continuously learn and improve. And 85% of people who gave feedback said that they would speak up again. So there's something about what can we do continually to improve the speaking up route so that it offers a well-received and a well-trusted system whereby people can speak up, but always to retain that possibility for people to be anonymous, because you never know what's happening in somebody's life, and we'd rather that people do speak up and have that opportunity to raise anonymously if that is what feels right for them at that time.
Thanks. Morwenna, you wanted to ask something.
Thank you. Yes, I wanted to testify to how scary it can feel to speak up in a public forum, being a not a visitor to the board today. I just wanted to ask Henrietta how we feel we're doing in terms of applying that lens internally, how we feel our own freedom to speak up culture is operating.
Well, thank you so much, Morwenna. And I think this is one of the real kind of unexpected sort of benefits that's come from freedom to speak up, is that so many national bodies have also taken up the opportunity to have their own freedom to speak up guardian. And at CQC, there are 3 freedom to speak up guardians who form part of our national non-provider network, and so can learn and share from all of the learning from national bodies. And one of the things I was really pleased about is that when we had October Speak Up Month last year, which was looking at the alphabet of speaking up, where people were able to share hundreds of different words that meant something to them in terms of speaking up, listening up and following up, that CQC really participated in that in a really positive way. So my feeling is that I think up until we had our first Freedom to Speak Up Guardian survey, there was never an expectation that national bodies would attend to their own speaking up cultures in the same way that we were asking providers to do it. And I see this as a really positive step on the whole journey, which is that when organisations genuinely listen to their workforce, that they can get that gift of information and that it can lead to learning and improvement. So I really think it's fantastic that CQC, along with many other national bodies, are participating in this and able to get that learning and share with each other as well.
Thanks, and I think we'd echo that from our side of the table, as it were. Mark Saxton, welcome back.
Thank you, Chairman, and Henrietta, thank you very much indeed for another super report from you. I took a couple of things out of it, just want to comment on it, and then I have a question. I think it's really good to see that there's a focus on not only the issue that's been raised being dealt with, but then expanding the learning of that through the organisation, through training and applied learning. That, of course, is going to be a way that you get to some consistency and improvement in the way that that people are managed. and delivers stronger culture and stronger leadership. So it's really good to see that focus in your report. I can't say I went into all your reports, but I did go into the data one and picked up the bullying percentage of speak up events, and then sort of link that to that terrible story that you put in your annual report about the BAME junior doctor, which is a salutary lesson and something that we see in the NHS employees survey, the bullying of staff, and so this continues to be an issue, and your process continues to shine a light on it, and we need to improve that. But also in the data report, I picked up on the link of the capacity to speak up linked to the size of the organization. I think that makes sense, but I wonder whether there's not an opportunity for you and Speak Up Guardians as we move to more system-led approaches, whether there isn't an opportunity for those guardians in the bigger organizations to buddy up with the guardians in the smaller organizations to encourage greater confidence and capacity to speak up. So just wondered whether you had been looking at that as an organization.
No, that's really a really kind of key point. And I think one of the things I would say is that as much as we can have data, it's the stories that tell us so much more about what's happening inside an organization. And I don't think there's a chance that we can have speaking up as business as usual until the full inclusion work has been done, because working really closely with the Workforce Race Equality Standard and with other workforce networks across NHS Confed and NHS England, it's absolutely key that this is only going to be right when we've got it right for everyone. And going on to your point about the working across systems, Guardians are already working across systems. So whether that's Dorset ICS or Bob and others, Manchester, we've got Guardians working really closely across patient pathways. And I really welcome that, because as a GP, I know that it's the gaps that exist between the organisations. And I caught the tail end of a previous report that you were discussing, that it's those gaps that make all the difference. Now, we already have really good linkages, for example, with the Guardians in the ambulance networks and the providers, in which they're bringing the patients and delivering care. But it's also really important that we work across primary, community and acute sectors with mental health. And for example, there are a number of trusts who have acquired GP practices, and we're particularly interested in how they are delivering freedom to speak up into those primary care organisations. So as the landscape of the NHS evolves and continues to evolve, we're evolving with it. And with Model Hospital, there's also a model system, and that will help to support data in terms of how we look at that across systems. And with our regional networks and the sub-networks that exist within those, we're really interested in how Guardians can work closely together. There are some legal aspects around who you can speak up to, and we want to make sure that we never put somebody in a position of being vulnerable, that they happen to have spoken up to the wrong Guardian and that they don't then get the protection that they might need in the future. But I think that's something that we can work together with policy in terms of developing the correct policy wording, so that we can get that level of buddying and support working across systems in the future.
Thanks. I'm going to go to Ted and then Sally, and then we'll let Henrietta get on with the rest of her life. But Ted.
Yes, well, thank you, Henrietta. And just to reflect your report, I think we've seen real progress in this area. And I think the COVID pandemic has been a great example of seeing the progress in this area. And as I've said already in the board, I really greatly welcome the fact the staff have been speaking more freely about their concerns during the COVID pandemic. And I think that's real indication of the way we need to go if we're going to drive the safety agenda that we're so keen to drive. I think your Freedom to Speak Up work is absolutely central to the safety agenda, creating a culture where people openly talk about problems and get them sorted rather than keep them hidden, I think is going to be so important going forward. Just to pay a big thanks for the support you've given to our inspectors in developing and supporting them in taking the steps necessary to understand this agenda better. We are very committed to building it into our well-led framework going forward. We think it's really important to drive this agenda. We are, as you know, Henrietta, in some ongoing discussions about the regulation review to see if we can improve the way that Freedom to Speak Up is reflected in the regulations going forward. But as I sort of said, this is mostly about leadership and culture, not regulation, and I totally recognise that.
Thanks, Ted. Sally.
Yes, thank you, Peter, and thanks to Henrietta for both the report and congratulations on the progress that you've made. I'm really struck by the strapline, if you call it, around listen up, speak up, listen up, and follow up. And I know that you've got ambition around follow up and leadership. And I just wondered whether you could say a little bit more about that, and perhaps you and Robert would like to comment on anything specific that CQC could do to help you with that.
Well, thank you very much. And yes, absolutely. As Mark was saying earlier, you know, fear and futility. And the futility aspect is one that we really want to work on as well as the fear factor. Because if people speak up and it doesn't lead to change, or they never find out about what's happened, then there's no kind of sense of that this has made a difference. But we know from the 100 Voices that speaking up is really making a difference in organisations in a really positive way. And when it comes to leadership, I mean, I would really welcome the board of CQC committing to undertake the training that we are developing with Health Education England, because I think that really would role model it to the rest of the system. And I think it's quite good training as well. I mean, I wouldn't impose something on you that I didn't think was going to be useful. We know from our survey that of Guardians that when it comes to detriment, the prime kind of where that comes from is from managers. And so if managers have the support and the knowledge and the skills, so that when somebody does speak up to them, they know what to do, and it doesn't feel fearful for them. And also for leaders, I go and visit lots of organisations, and the boards are really enthusiastic about this, but it's got to filter all the way through the organisation as well. And when it comes to leadership is something that we work in partnership with many organisations on this, in particular NHS England Improvement, who have huge amounts of resources and support available for leaders of organisations. And I'll just give an example of that, which is the NHS Leadership Academy. Freedom to Speak Up is part of the Rosalind Franklin training. It's part of the Aspiring Chief Execs programme, and there's a desire for this to be embedded into all leadership development. So we can't do this on our own. You probably know that my team isn't huge, but we have huge ambitions. And so the way that we're going to be able to deliver that is through working with others. So thank you very much.
Robert, last word to you, then we'll move on.
Well, thank you. I don't often get that, do I? Well, I think a specific answer to Sally's question is firstly to continue developing what we already are doing, which is to highlight the fact that when a regulatory intervention or an inspection is due to people speaking up, we to the extent possible, we say that and we give credit to that. And I think we've been doing that more and more over recent times. And I think that is a way of encouraging other people to do the same, because they then see a result. But the second thing is about, I think, a bit about leadership and scrutiny of leadership and accountability, and sort of taking the example of the question I asked Henrietta about the conduct of some trusts leadership in relation to grievances that arise out of speaking up that's gone wrong in the past. There tends to be an attitude, well, that was in the past, we'll now treat this just as a legalistic issue, rather than firstly as a learning experience, and secondly actually providing where necessary recognition to the individual who may have been wrong that that has happened. And I think that that's partly a leadership issue which could be scrutinised through the inspection and oversight process. At the extreme end of the scale, there is the use of, or potential use of, the fit and proper person regulation, which we, through the CART review and so on, I think now generally agree needs revision. Because I think there is a feeling among some people I talk to who've been at the wrong end of all this, that that there isn't as much accountability as there could be in relation to the really bad cases, and that people are potentially still floating around the system who have a record about this. So I'm not suggesting for a moment CQC can solve all those problems overnight, but it does seem to me that's an area where we could focus a little more on to see if we can provide some benefit through that.
Great, Robert. Thank you. Henrietta, first of all, you issued an invitation, and I think perhaps Ian and I could talk to you offline about how we progress that. Secondly, let me just say it's always a great pleasure to have you at our board. You always invoke great discussion, and you did it in such a nice way. So it's lovely. But I think it's also great that, as Robert implied in his first, he had the opening and closing words this time when he spoke immediately after you. If you look at the first annual report you produced and you look at the most recent one, the progress is just stunning. It really is. And I just want to congratulate you, because I mean, this has all come from your personal drive to achieve it. So thank you very much for all you do on behalf of all of us.
Well, thank you so much, Chair. And the thing I would say is, yes, there's progress, but it's such a huge, huge area that there's still a huge amount to do. So the more that I can get the support of you, your board, and the entire organisation to help drive this in the right direction is what the system really needs.
You have it, and we'll see you, Henrietta, somewhere later in the year, I'm sure, before we get to this time next year with the next annual report. So we'll see you midway through the year, I'm sure.
Thank you so much.
No, bless you. Thank you very much indeed. And that takes us to our last substantive item on the agenda, which is the Healthwatch England quarterly report. Robert, are you going to introduce it?
You're getting fed up with my voice, so I'll be quick because the Melda's been sitting there patiently now for some time. But if I could just say three things. Firstly, pay tribute to Imelda and the Healthwatch England team for the brilliant way they've just continued business as usual through the pandemic, replacing, needless to say, real physical meetings with remote ones, supporting the network of local Healthwatch through really difficult times in some places, and while at the same time producing, as you will see from Imelda's report, really impressive work in relation to issues arising out of the pandemic and getting change as a result, which is perhaps the most important thing. I'd just like to, that's the first point. The second point is that you will see that our committee has undertaken a refresh of our strategy, and the fruits of that are seen here in what is in effect our business plan. And we have recognised, and the pandemic has highlighted this, that there's a real need for a focus on health inequalities, and through our lens that means a focus on seldom heard and vulnerable groups in different communities, because Healthwatch, being present in every local authority area in the country, has a particular skill in being able to identify such groups, to find them out and get their experiences and information about their needs and feed that into the system. And we believe that although it's set out as a separate strategic objective, is in fact something which is going to inform all our work. So anything we do will have a consideration in it of the health inequality or EDI perspective. And the final thing to mention is our place in the post-white paper world. And we take the firm view, with which I hope you agree, that it is vital that Healthwatch has a presence at ICS level in the new environment. And there are very constructive conversations going on with the department and with NHS England about what form this should take. But it does require a recognition that our scope of our activities would increase from what they are now, and that we would certainly need really, and the network in general would need an increased resource to provide the service at ICS level, to make sure that local voices were properly taken into account there, and also, just as importantly, that information from that level is being fed back to the public locally. So those are the three things I wanted to say before, and I don't want to spoil Imelda's pitch, so I'll hand over to her.
So Imelda, I should have welcomed you at the start and I didn't, so I apologise. You're extremely welcome, and over to you.
Well, thank you, Peter. I always feel welcomed at these meetings, so really it's completely fine. So what you got from us, I'm afraid, is a very long document, which I didn't expect you to read the whole thing. But this time of year, we, as a sort of to keep you informed and as a matter of transparency in the public domain, we've also sent you our business plan for the coming year, which we've done a lot of work on. So just a sort of reflection back on the last few months, and I'll just pull out a few highlights of the things that we've focused on. One of the things that we've really focused in on is the vaccine rollout, and we've been focusing in on vaccine rollout in a number of ways. One is making sure that we really get information out to the public so that they know how to access it appropriately. We've also done quite a lot of work with around particularly some groups that were being, there was an agreement that they could have the vaccination, but it wasn't getting through to the public. It wasn't coming out in messages like, for example, carers. So a lot of work on vaccine rollout, getting quality information out to people, but also doing work on vaccine hesitancy. And two pieces of work on that. The first piece of work, we did some polling, and particularly Black Caribbean, Black African and Pakistani people. And we found out that there wasn't a huge amount of hesitancy about the vaccination, but there was a great deal of hesitancy about getting to vaccination centres. So that really helped in working out how we can then help roll out the vaccine. And the next piece of work we're doing is a much more in-depth piece of work, a bit more like ethnographic work with the NHS Race Observatory on really unpicking the remainder of that hesitancy that we see. We've done quite a lot of work on the 111 First programme. We were involved with NHS England through Steve Powers pre-pandemic on work around A&E and what the public needed from it. And one of the things that the public talked to us about was how useful it would be if they could pre-book A&E appointments, and it came up with back with a lot of resistance from a lot of places. Actually, in the pandemic, we moved to that, and so the pre-booked A&E appointments, there's quite a lot of satisfaction with it. There's great awareness of 111, but not such great awareness of the ability to book appointments through 111. And I think this is one of those change management things that NHS really needs to understand more. They do some really great change management, but that bit about following on the communication to the public is often the missing step. And so we want to do more work on that. We've done a lot of work, and I know it's a big issue for you too, around access to dentistry. It's the biggest issue that's come up, and it was a big issue before the pandemic, but the number of people coming to us saying they can't get a dentist has gone up a huge amount. I think it's 425% during the pandemic. So we're working with a range of people on how people can get better access to dentistry services. Likewise, and just this week, we've published a report on people's experience of trying to access GP surgery appointments, and that report is based on the experiences of over 200,000 people who've talk to us about how it's been for them, some of it pre-pandemic and then some of it within the pandemic. And that's a piece of work that will continue into next year, where we're going to work in partnership with the General Practice Managers Association to look at some of the pragmatic solutions to the problems that people are talking to us about. Our relationship with the network remains very, very strong. We've had a huge response from them, and just in the last year, over 3,000 people have attended our training, which is up about 30% from previous years. We have a big lead at the moment on equalities, diversity and inclusion issues, particularly working with the network, so setting up action learning sets, setting up Black Workers Network, and a whole host of things to really get that work moving, and it's a very top priority for us in the coming year. We're also undertaking quite a big, I mean, for us big, for you tiny, digital change program, because we believe that some of our systems and processes prevent people from sharing information with us, and our data shows us it's often people in the big large conurbations, the Healthwatch and the large conurbations, that aren't sharing as much with us, and that's where a lot of the seldom heard groups are. So we're doing a big piece of work on that. Our advice and information service has really stepped up in the last couple of years. It was a priority in our strategy, and during the pandemic we've seen a rise of 720% in people accessing our advice and information, and you'll all know how rapid that has been during this time. You know, the guidance on visiting care homes, the guidance on shielding, the guidance on vaccinations and so on. It's a rapidly changing situation. But I think our team have done really well. It's a small team, but we've done really well to keep pace with that, and also make sure that the network has accurate, high quality information that they can pass on through communities throughout the country. And our final thing just to say is that we've had a really good year in terms of public feedback and campaigns. And I think the campaign that we've worked with you on particularly has gone very well. Because we all care, it's really helped informed a lot of the insight that we've been able to share with all the stakeholders that are relevant to Healthwatch England. So thank you very much for your time.
Thank you, Imelda. I think I've said this to you before, but I just get exhausted reading what you've been doing. I don't know how you feel, because you've actually had to go and do it. It's a fantastic volume of work you get through, and all incredibly important, I think. Chris, you wanted to come in.
Just to echo Imelda's thoughts and to thank her and her team for the work that we've done together to reach people across the country, to make sure we can get their feedback, to make sure we can act on it, to make sure we can use it in terms of our regulation. Her team, as you rightly say, Peter, are tirelessly working that both at the national level and also at a local level as well. I just want to thank her and her team for her continued support, and also in the way we go about developing campaigns for things that we know we need to address together. So I think I just wanted to echo Imelda's thoughts and to offer my thanks to her as well.
Thank you.
Thanks, Chris. Rosie.
Yes, just to echo that, Imelda, we've worked very closely, particularly over the last few months, with your teams around, particularly around GP access, but also around dental access. And there's some great collaborative working going on, which is really adding to the work we're doing. So thank you very much for that. And also just to say, I thought your GP access report was great, and highlighted a whole range of issues that we all need to focus on. So thank you very much.
Thank you. I'll pass that back. I've just come from a morning session where the team were looking back at the highlights of the year that we're just leaving, and I felt quite emotional at the end of it, because it is a small team, and the amount of stuff and the drive that's there in every part of the organisation is amazing. So somebody who talks about the digital team, it's a person. It's a person dealing with 151 organisations and driving change through that. They're an amazing bunch.
So you're over resourced, Mark, obviously. Mark Saxton, you wanted to pop in.
Thank you, Chairman. Imelda, thanks very much again for a really good and thorough report. In the past reports, you have focused on transport. You've mentioned that in terms of vaccine hesitancy and transport access. As we come to terms with living with this COVID experience and moving forward and working on the backlog that the NHS is faced with, transport again is going to be an issue, and I wonder whether you will still be finding that information and communicating it in a way that's had such a big impact in the past.
So it's a good question, Mark. The work on NHS England, you'll remember, promised a review after we published our findings and began that review. But actually during COVID, rightly, it became about how do you provide patient transport during COVID? And now they're ready to start doing the broader piece of work. And I have a meeting next week with NHS England about how they're going to pick that up and take it forward. But we also take it into any of the conversations we're having. So the conversations that we've been having about the 40 new or reviewed refurbished hospitals, transport, hospitals can no longer see themselves as an island, and most don't. They've got to think about how do people get to and from. So it continues to feed into all our work, and it was interesting to see it come up in the vaccine hesitancy work, because I don't think anyone else would have picked that up in that way.
No, absolutely. Good to hear, and look forward to hearing progress on that front from you. Thank you.
Sure.
Great. Anybody else, or shall we let Imelda go and get back to her busy day? Imelda, thank you very much again for coming, but thank you also very much for all you and your team do. I think it really is a very important contribution to health and social care. So thank you.
Thank you. Thank you for your time.
No, thank you. Any other business from anybody on the board? I only have one thing to say, which is that I've just been told that the live streaming failed, and therefore people who will be getting to hear what I'm saying will have seen it at a later date. But I just want to apologise to everybody. I don't know what the technical problem was. It was certainly our intention to have it live streamed, and it was all set up for that to happen. So apologies, and hopefully it'll work next time properly. So if there is no other business from the board, that ends the board meeting. But we do have 3 questions from the public, and we've got time to take those. So let me start with 2 questions from Robin Pike. The first is, how does CQC check that care homes that should register do in fact register? There are some suggestions that minor organisational changes within a care home may seem to remove the requirement for registration. Kirsty, do you want to take that one?
I will, thank you, Peter. So I think there's probably 2 scenarios here. One is that a service that is unknown to us is unregistered. So we'd only know about a care home that is not registered if we are informed by the public or others through our intelligence. When we do know, we will follow our unregistered provider process to investigate if regulated activity is going on, and we can prosecute as necessary. So that's one scenario. The other scenario is that a known registered service provider that may change or does a minor organisational change. So if it's a minor organisational change, we would not really change the fact that a care home needs to be registered. If the issue is regulated activity, for instance, accommodation with nursing or personal care is happening. If the regulatory activity changes, then the care home may not need to be registered. This would trigger an application from the provider to vary or cancel their registration, and we would assess this. We could refuse a change, for example, if a minor change is unlikely to result in a change to the regulated activity. So I hope that answers the question.
Thank you, Kirsty. And then the second question, I think, will be for you, Rosie. It's, how does the Commission monitor patient access to primary medical services when GP staff are also working at vaccination centres?
Thank you, Peter. So we have a variety of activities that help monitor this. Firstly, with our TMA activity, our monitoring activity, we do look at access as part of that and the conversations that we have with providers. We follow up any concerns that we hear through inquiries or follow up any concerns we hear from our local intelligence with our partnership working with CCGs and local Healthwatch and other partners. We also ask about access on all of our inspection activity that we undertake.
Great, thank you. And then the last question is from David Hogarth, and he says, in the March Care Home Professional magazine, Kate Taroney, so I guess, Kate, this is going to be a question for you to answer. Kate Taroney said that where intelligence about a service indicated an improvement, an inspection could be held, which, if positive, could lead to a change in rating and additional capacity becoming available locally. Does the CQC accept that no inspection can definitively verify information of concern alleging possible abuse or neglect, and that where such unverified intelligence is held, either the information will be checked out by surveillance or moves to uprate the service will be abandoned? Do you want to have a go at that one, Kate?
I will do. Thanks, Peter. So I think we're talking about two different things here. So thank you, David, for your question. As I mentioned earlier on in board, it is a priority within adult social care in the CQC to go out and re-inspect services where intelligence says that they may be currently rated as inadequate or RI, but actually they've improved the quality of care, and information from local authorities and clinical commissioning groups back that up. So in those circumstances, we would go out. If we found the service to be good, we would re-rate and therefore open up capacity. David's question, I think, is about whether our inspection activity can confirm whether there is concerns about the quality of care being delivered. I absolutely do believe our inspection activity can ascertain if people are receiving poor quality care, and where we find that is to be the case, we can obviously take appropriate regulatory action. And also, as David is aware and as board are aware, we are continuing to explore our approach to how we use surveillance through our closed cultures work, and we will keep board and the public updated through this route.
Thank you, Kate, and thank you, everybody. I think this is the first time in 5+ years of chairing the board it actually finishes at precisely the moment that we said it would when we put the agenda together, which is quite astonishing. So I'm not going to allow any other business. That is it. We'll finish, and just thank everybody very much for what's been a very good morning's work. Thank you.
Thank you.
Thank you.
Thank you, Peter.
Thank you.